And how will the government actually address persistent challenges such as health worker shortages, burnout, and rural retention? Tonight here on The Probe, with the expertise of the Director General of the Ghana Health Service, Dr. Samuel Kaba Akoria, will examine the accountability mechanisms in place to track performance of this policy and ensure value for money. Of course, we'll be interrogating the financing model, its cost implications, long-term sustainability, and potential impact on the National Health Insurance Scheme, which has become a major issue, as well as its alignment with the Ghana Medical Trust Fund, what we know as the Mahama Care. But to put the conversation into context, let's bring you excerpts of what the policy document actually contains. And you have it there on your screen. The free primary health care policy launched by the president himself, President John Mahama. And the rationale for the primary health care, according to the policy document we have seen, about 10 million Ghanaians are actually not actively enrolled in the NHIS as we speak. And of course, some families continue to still pay out of pocket for basic healthcare services across the country. And let's continue to see how Ghana's previous approach to universal healthcare coverage has been like. There have been some rollout of Chiefs Compound. If you know, in your own communities, you can just go there to access healthcare. That has been on the table for some time, and it has been implemented. As to how it's working, we're yet to really know. Then the National Health Insurance Scheme or policy was also introduced. These two key steps were taken to ensure universal health coverage for the country. Now, the availability of basic health facilities in healthcare, equipment in healthcare facilities across the country. If you look at the screen, you'll see that just 5% of those, equipment are in all facilities across the country. Now, if you go to the public facilities, you'll find out that just 2% of all healthcare facilities actually have full complement of basic health equipment across the country. Now, we can now look at the free primary health care policy and its coverage. As we have been told, we are told that Chiefs Compound will be implementing it or will be benefiting from it, as well as health centers in communities also. Also, there are polyclinics that will be part of this particular rollout. And healthcare workers, we're told, will be visiting homes to actually, carry out some checks on all of us to ascertain if we have some conditions or not. That's what the policy seeks to do. Now, any Ghanaian with a valid national ID is qualified. And so we don't know if foreigners who are in our country can actually benefit. We'll be finding out from the Director General of the Ghana Health Service here. Now, let's look at another aspect of the policy in terms of cost. We are told that this policy, the free primary health care policy, is going to cost the taxpayer 1.2 billion cedis every year. Now, where is that money actually going to come from? We'll find out. And how sustainable is the issue? That's what we are probing tonight. But of course, this broadcast is live on DSTV, channel 421 and GoTV 125. On radio, we are on Joy 99.7 FM in Accra and Love 99.5 FM in Kumasi and over 30 affiliate stations across the country. And you can be part of this conversation. You can join us on social media at Joy News on TV or watch us live anywhere in the world on myjoyonline.com. My name is Carlos Calony. When we return, we go straight into the conversation. This is The Probe. Stay with us. Welcome back to The Probe. Now, resetting Ghana's healthcare system is the shift from treatment to prevention feasible? Is it sustainable? And is it affordable? That's the big question we're asking here tonight on the probe. And Director General Ghana Health Service, Dr. Samuel Kaba Akoria, is my guest tonight for this conversation. Grateful for your time. What is wrong with Ghana's current healthcare system? For which reason we need free primary health care policy?
Thank you so very much, Mr. Carlos, and good evening, Ghana, to His Excellency the President and all those viewing. You know, I want to take this opportunity, right, to really explain from a practitioner point of view, an implementer point of view, what we are talking of. And then after that, there's Ghanaians who take it to say, okay, is good or not? Is it feasible or not?
Okay.
That would be a question every Ghanaian will answer.
At the end of the show, we will determine that.
And I will start with using myself. Fortunately enough, I had the opportunity to grow up in Cuba at the age of 14. I left this country. I spent 18 years in Cuba, where healthcare is free.
In Cuba?
100%. After I graduated as a neurosurgeon, came back just for the purpose of the program. I spent another time in Spain, 5 years. So 18.5, where healthcare, primary healthcare is free. Healthcare is free.
In Cuba and in Spain. Right.
If you look at these countries, and all countries in the world, life expectancy, I'll take the entire of Europe, okay? The countries that are living in good life, with good life expectancy, primary healthcare is free. Talk of Monaco is the first, followed by Spain. Talk of Germany. They started in 1884. How many years ago?
1884, when they actually started the primary health care policy,
gradually.
Free.
And they went gradually.
Over 200 years ago.
Over 200 years ago. And we are still here debating whether it's feasible or not.
What's involved.
No, just imagine.
So
okay?
Of course, we can't compare ourselves to Germany and those countries you're mentioning.
Exactly, because they started from somewhere. They could have also said that, let's wait, but there is no time to wait. But then let's come to Africa. Let's look at all the African countries that have good life expectancy. Okay? You talk of Algeria, right, in the northern part, right? You come down, you talk of South Africa, you talk of Botswana, you talk of Rwanda, right? It's simply because they've implemented what is free primary health care. And it's slated on 4 C's. First is the contact. Second is how comprehensive it is. And third has to do with how you're going to keep on the continuity, how you're going to coordinate it.
Sustain it.
Coordinate it.
Okay.
And then after that, you continue it. So you have the 4. Okay? Now, this is what it is. 2012, I want Ghanaians to understand with examples. I was the Director Institutional Care Division of Ghana Health Service. I'm a neurosurgeon by profession, and I see almost on daily basis people with stroke. And when you have stroke, you have 2 possibilities. You die or you survive. When you survive, the next thing is you remain disabled or you recover. But for that, either you get surgery or you don't get surgery. In any of the cases, it's extremely expensive. I embarked on a trip. I went to, I think, Keta to inspect a hospital. The hospital was the best 3 consecutive years.
In the Volta region?
In the Volta region. When I got into that hospital, it's a district hospital. The hospital director says to me, we need a cardiologist. And I'm telling you, 2012, 14 years ago. Ghana Health Service at the time had only 1 cardiologist. The rest were in the teaching hospitals. Yeah. We went to each of the wards, and there were people with strokes. So at the end of the day, I said to my driver, let's go. I don't have a cardiologist, but there is something here I need to figure out. When I got into the car, we drove off. In the middle of the way, I said to the driver, why did you take this road? This is not the road we use. He said, no, this is the shortcut. I used to drive the lady who we used to come here to mine salt. I said, make a U-turn. Let's go back to the hospital. You just gave me the response of their problem. Went back to the hospital, okay, I called the hospital director. I said, look, this community is fisherman community. The water body around is salty. They mine salt here. Their food is salty. They do fisherman soup. And then after that, they drink a little bit of alcohol. It's all hypertension. And that leads to the stroke. It takes me 6 years for a doctor to graduate, all right? 2 years for housemanship, all right? And then after that, it takes about minimum of 4 years to become that cardiologist you want. So 12 years. Don't talk about cost yet.
Cost of training the
cardiologist that you want.
Right.
Then after that, I need to find a way of sending him to you. Accommodation, X, Y, and Z that we all know. But now, this is what I want us to do. I don't have that cardiologist. I want us to change the lifestyle of the people. Right? For them to now understand that the problem of the hypertension that they don't know is, one, because they are not being checked, and two, is because they've not sorted out their surrounding, their environment.
In terms of lifestyle, eating.
In terms of lifestyle, eating. If we are able to engage them, then we will reduce that. They will fall less sick. They will need a cardiologist. The country will save more money. And the stroke, when you suffer stroke, people don't even have an idea as to the cost. When you remain paralyzed, it doesn't end there. Every movement you have to do, somebody has to accompany you. You've condemned that life too. The next thing is that when you go home, you have to restructure your house to fit in a wheelchair. You're talking about a minimum of $200,000 by the end of the day of taking care of a stroke patient. Which one is expensive?
A minimum of $200,000
and more
a year.
No, depending on the kind of stroke you have. Going through physiotherapy, rehabilitation, you have to cost that. Costing the other person's productivity that is carrying you up and down. Costing your wife's or your husband leaving work and coming to attend to you, visit you at the hospital. Those are overheads we don't know, right? But they are very expensive.
Right.
It has no price. And when you die, we can't bring you back. But we can change that lifestyle. So the first thing is that Ghana is not starting from zero. Way back in 1994, we introduced the concept of the CHIPS, okay, which is primary healthcare, the backbone.
1994.
And now you listen to the interesting thing. People talk of it. And I'm so happy because I introduced the issue of Cuba and Spain and all that for a reason. The CHIPS is community-based health planning services. Do you get the whole concept? It's about the community, a health that you are going to plan together with the community based on the community needs. Right? And then you deliver those
So the
services.
needs in Keta will not be the same as the needs in Kokomlemle, for instance.
Exactly. But there is another, something more to it, that when I look at you, right, and I talk about health system, right, I need to understand that it starts with the human being, the individual, who lives in a house, so the household, and that house is within a community. So now you're talking about that community and then up to the country. So the community-based health planning services is now for that person to come to your house, talk to you, and say that you have this disease, this disease, this disease. But it doesn't end there. It says that, oh, it's because of your environment. Maybe you are asthmatic and there are some flowers just by your window, and that is why you get into crisis. The health worker will educate you about that. You move them, you don't need to wake up in the night because you have asthma crisis. How much does it cost?
That is what the policy is about.
I'm breaking it down for the ordinary Ghanaian to understand.
So when it comes to the chiefs, let's get a clarity.
Yeah.
It's not that this policy is replacing anything at the chiefs compound level. Is that the point you're making?
So, the point I'm making is that right now, until we launch this policy, at the chiefs compound level, services that were provided, okay, are static. That people go to the chiefs compound. And then they get services which are more like curative. And then they are reimbursed by the National Health Insurance with your card. Okay. Now, this policy is saying that I'm sending the people to your house. They will be in your community. They will plan with you, because no matter how much we health staff, we try to drive out a disease. If the community is not in agreement, it won't happen. So we will involve the chiefs, the opinion leaders, the queen mothers. We will involve you, the individual who is sick, to understand your problem. Maybe we are talking of mental health. We say, okay, but it's probably from your household. It's probably from the community. So we will have that dialogue identified. So the nurse is not coming. I've been hearing people, so we will take your BP, we will do this. That is true. But we are coming with an organized checklist. In that checklist has to do with taking your BP, taking your glucose, talking to you, trying to modify your lifestyle, understand the diseases around you, making you understand those diseases, and together we will now plan an intervention. And that, we say, is for free. It won't cost you because I've come to you. You as an individual, as a Ghanaian, it won't cost you. But government will pay for that. Is it not something new that you sit in your house, somebody comes in and does that?
Those professionals at the chief's compound now have additional duty beyond providing medications to members of the community. They're going to go into the community to more or less do assessment, health assessment on families. Okay. That's the new thing about it.
That's part of the new thing.
Okay. Because what else would they be doing at that level?
At that level, beyond that, beyond just taking your BP and the rest, is fundamental planning together with the community to understand what is the problem of the community and how to come out with intervention with the help of the community.
What is planning, if you can explain, with the community?
I'll give you an example. This year, it's not been too much news because we did something unique. Meningitis season usually starts there about December, November, coming till date. I was born in the zone. I had my classmates die in front of me. And I said to myself, no, enough. Over 100 years, the same disease kills the same day, the same time of the year. And we watch and sit down, there should be a problem. Either the community doesn't understand us, or we don't understand the disease, or we don't involve them. So before it started, we issued an alert. After that, we followed up. I traveled around with my team. It's a teamwork. Let me make this clear because it's a teamwork. Went around. We met with the communities. We even appointed some of the chiefs as meningitis ambassador. And we told them, look, it's about hot sun, it's about humidity, it's about just put a pot here with water. It drains the sun. Under a tree, you sit, you converse, you're fine. Leave ventilation. Today, we are not being blasted because of meningitis. Do you agree or not? Last year, I was everywhere. They were saying, "Oh, this is number of deaths, 30-something."
Yes. we did a lot of stories.
Today, yet, did you do many stories? How much did we invest in that? And we had good results. So that is about this policy.
The planning.
How to plan with the community. And they themselves reacted. The chief led it. He's now the ambassador of meningitis. We didn't pay him, but he saw the need for his people to survive. His people listened to him. People that when we go there to talk to them, they wouldn't have listened to us. And they came out and said, okay, from the community point of view, this is what we can do. And then from your part, what can you do? So we can give you more education on this. We will give you the medication should you fall sick at no cost. So come early to the hospital. You get what I mean?
Okay.
So that is being done. But there is another thing about the policy.
Okay.
If you are in your house and the nurses come to your house and they find out that you are sick, okay? They will now send you to the next level. One is the preventive and promotion. Let's say I found out that you're sick.
So let's remain on the preventive first before we go to the movement to a health facility. What specific health conditions are they going to come look out for?
You know, as I say, it's a checklist, and it's about One Health.
Let's go through that checklist.
Yes, and it's about One Health. So we start screening services. You as a person, we need to look at you. I get into your house. Let's say the chips has a demarcated area, zone, okay? Then we say that, all right, I am responsible for 250,000 people around, or 100 households. I'm giving you an example. When the community health nurse gets in there, he has the list, and he knows that we have 200 people who are hypertensive. We have 5 women who are pregnant. We have 3 newborns. Then he will say that, okay, I'm tailoring this to say that those who are hypertensive, we take your BP, we check this, we educate you. The newborn, we examine you and make sure that you don't have complication. The pregnant woman, you are also examined. We make sure that you are up to date with your antenatal. You get how it goes. And then the men, we can talk to you about prostate cancer. We might even have kids to be able to test and see how you are doing. So we are looking at those screening services. We are looking at those services that you say you are diabetic. We can easily measure your glucose and say, look, this is it, and this is your lifestyle. You have to modify it. You don't need to go to... And let's remember that the policy, technically, is to help the deprived people who have to drive hours
to the next health facility.
And let me say, we have a well-defined criteria as to who is deprived. I will share with you.
Okay.
All right. So these people otherwise wouldn't have had this kind of services. And now they will have them at their doorsteps, where we will give them that preventive and promotion measures, educate them, weigh them, talk to them about their eating habit. But as I said, it's One Health concept. We'll also look at your surrounding and say maybe you have a lot of roaches, you have to do this for the cockroaches. So
this screening includes conditions like prostate conditions?
It includes cancer, breast cancer. They will help to examine you. Prostate condition, it includes diabetes, it includes hypertension.
How is that going to be done when it comes to prostate, for instance? Because I know
No, we have some rapid diagnosis tests. Don't think about it. That
yes,
I saw it. Somebody asked me that. They said, we'll do a rectal tag, please. No.
So you'll be in your house and...
we'll talk to you about it, depending on your age, and educate you. You get what I mean?
All right. And then when they find someone sick at home, what happens?
Good. As I say, we are introducing something new there too. When I find you sick, I say go to the next level. What happens? You won't go. You say, oh, this. But with the nurses, we'll have nurses who call patient navigators. So at the next level, because we've taken your data and we already know that 100 are hypertensive, 20 are diabetic, we already know everybody's profile. It's the data. The next time we come, it's easy to deal with you. So
one of the advantages of this policy, if you understand you well, is to get the health profile of this country. Across the country. Or at least across the 150 districts that you're going to be piloting this, okay?
No, it's not a pilot, please. We are starting.
Okay.
Don't use that word because we are not piloting.
Okay.
We are facing it. I just told you Germany started free this in 1884.
Right.
And the last time they ended was 1994. When they actually enroll everybody. There are people who will say, do it immediately. Some will say, let's face it. We are facing it.
Okay.
All right? So you don't crash the thing. We learn from whatever we are doing. We improve on it, and we continue.
So you think this policy is going to improve data collection?
Excellent. For monitoring purposes, for evaluation, for intervention on the diseases. And it will limit every community for us to know the disease profile of every community.
Okay.
You get what I mean? Even every household will even know.
Right.
But it is to your benefit and it is to my benefit.
At no cost.
At no cost.
Let's go back to the chips company. I know you have a lot to say.
Chief, let me explain something.
Okay. Right.
As to when I find you, what happens. Because regularly people won't go to the next step. But we have established it in a way that because I've come to your house, I've found you, I am going to pass your name to the person at the next level.
Okay.
right?
Where the next level is.
This person, I've come to your house. So you come to the chief's level, okay? This person has this disease.
Okay.
So you are registered. At the chief's level, that's why we equip it. If we cannot, we say go to the health center, because that's why we retool the health center. And if not, the polyclinic, and if not, the district hospital and the regional hospital. What are we actually simply doing? We are now establishing and maintaining the gatekeeper system, right, for our referral system. And there will be somebody to help you. It's not you, it's not your responsibility as a patient to go and find a doctor at the next level or to find a physician assistant at the next level. It is our duty that we've found you, we've put you at the next level. And it's the next level's duty to book you at the next level and say, look, you've been booked for this day. This is the person you will see when you get there and you'll be taken care of. Is it not something new and it's not something nice? That
are we not already doing those things?
No. We have, I'll answer and let you know that our referral system has a challenge.
What challenge?
That somebody gets up right now from his home. He's having headache, small malaria. He's gone to Kolebu. Kolebu is not for that. And you can't send him back. He's having diabetic crisis. He's gone to Kolebu. He's jumped all the levels. But with this policy, right, we would have even known that you are this and would have even booked you at the next level. And you know that at the next level, when you go, there will be somebody to attend to you. You don't need to know somebody before you get attended to. We want to eliminate that kind of health system where you need to know somebody at the next level before you go there.
So you're telling us tonight that this new system is going to address our referral system?
And gatekeeper system.
How?
Because the way it is, as I explained, is that you don't get up on your own and just go to the highest level. We would have detected it at the lowest level. We will book you at the next convenient level. When you get there, you actually know that they are waiting for you because you've been booked for this day. And this is the pathology or the disease can be handled at this level. That's why you are there. When they finish with you, they will give the person who sent you, when I say person, I mean the chief's compound that you belong to. They will know that this is the treatment you have and you go home. The next visit of the nurse to your house, when he comes, he will ask you, how is your disease controlled? So you are being followed up to the top and to the down. And then you are not paying absolutely nothing. Now, I will make it simple for Ghanaians to even understand, because of the people I want to direct this to is the deprived areas so that they will understand. In Ghana, let's say education. If I ask a Ghanaian, what is basic education? They will talk to you about primary school, kindergarten, GHS, SS, and we say it's for free. That's basic. And we are now saying that in the health sector, what is primary? Your P1, P2, P2, P6, your basic. What is basic? The basic is that every Ghanaian, right, who goes to a chief's compound, a health center, a polyclinic, as long as you provide or produce a card that shows that you are a Ghanaian authentically.
Are foreigners going to benefit from this?
As patients, yes. But as I said, as long as you produce a card as a Ghanaian. We'll come to that. But we will not leave any person untreated because you are not a Ghanaian.
Let's go back to
as a Ghanaian is free for.
Let's go back to the referral system. We have a lot of questions for you. In times of emergencies, people usually would want to go to the highest facility. So if I live in Tema Community 1, for instance, and there's an emergency, the first point of call would not be Tema Polyclinic. I would want to go to Tema General Hospital because it's the referral center. Are you saying tonight that that system will no more work?
You see, you have a system, you are talking of emergency.
Emergency, yeah.
If a car hits you on the road and the bystanders, the first people to find you, could be a taxi driver, could be a farmer, depending on where you find yourself. The intention is to go to the nearest facility. Okay. Now, that nearest facility could be a chief's compound. It could be a health center. It could be anything. And this policy has retooled or is retooling these facilities to be able to provide that first aid for you. Then comes the next step. Once you get there and you get the first aid, they are able to determine which level you'll be going to. Then the national ambulance system will come in. They call it, and then it takes you to the next level. So, but they will coordinate. I said this before. You see, I'm very, very passionate about this because 2018, right, we had a no-bed syndrome issue. 70-year-old who died and they moved from hospital. I was the one who chaired that committee. I was director ICD at the time. We came out with all the necessary things, right? We have it again. I'm the director general. I can't complain. I have to fix it. That is why you probably don't see me talking, because I'm concentrating on how to fix it.
Okay.
I've seen a policy that will help me fix it. And this is the policy we are talking about.
How is this going to address the no bed?
Because at the end, the first thing is that, Mr. Carlos, listen, I've come to your house. You were hypertensive. You didn't know. You didn't know. The natural way is that one day you are there, stroke. You are taken to Kolebu. But now I've come to your house. You are hypertensive. I've detected it early. I've given you your medication. You don't fall down. Have you not freed a bed in Kolebu? Yes or no? You've just freed a bed in Kolebu. You are diabetic. You go into crisis. You didn't even know. I've come to your house. And I'm saying that, Chief, this is your sugar level. Do this, do this, do this. So you are fine. Supposing that you are not able to do it well, I'm saying that this is the chief's compound where you belong to. Over there, Madam so and so, we all know you profile.
We're giving you your medication.
We know that immediately we see you is because the first thing in our head is that you are diabetic or you are hypertensive because we know you. So when you come, we give you your medication. Will you go to the next level? Have I not freed a bed?
So that's how this is actually going to address the no-bed syndrome.
Yeah. It's another way of addressing it. Again, let me even make the conversation even better. When you get that stroke, okay, you get to the higher level, and we have to operate on you. It's quite expensive. You have to pay, all right? But now, health insurance is to reimburse that treatment at that higher level at a cost that we don't know, right? But now, because we've been able to detect it early, now you are not going there. We freed money to health insurance.
So you save money on the health insurance. You're not going to be spending so much on the reimbursement and all of those.
At the beginning, when we start this, okay, this is what will happen. People will rush because people don't understand. And that is why I prefer to spend 5 minutes with you to explain the system. Because the system is not that when we start and we say we are doing free primary health care. I say when we start because we have to finish rolling out the retooling, because once the president launched it, we started. Okay. But he said we are going to do it over 2 months.
Stay with us. Stay with us. We have to take a quick break.
Yeah.
When we come back, we'll be discussing the retooling aspect of this policy. And of course, this is The Probe, and you are listening to us on Joy 99.7 FM, and we're also live on Joy News here. And we'll take a short break. We'll return and we'll continue with the conversation with the Director General of the Ghana Health Service. Stay with us.
Cadbury hot chocolate, crafted from cocoa, milk, and sugar. Creamy, chocolatey, frothy goodness, rich taste, so satisfying.
Cadbury goodness, the treats you deserve every day.
Turn your home and office design dreams into reality. Here at Lesh Fortune, interior design is our passion. Customized interior design solutions, top-of-the-range products such as curtains and accessories, blinds and accessories, trendy for bespoke hotel, home and office furniture, top-notch space design services.
I'm the CEO of Builders Estates. When it comes to putting the final touch on all my building projects, I look no further than Lesh Fortune for all my interior decoration needs. They bring your ideas to life.
Turning your house into a home takes more than just access. You need beauty and elegance, and the expertise is very important. That's why I choose Lesh Fortune Limited, because they have experience.
Yes, indeed. With our many years of experience, we would excite you. So make that call now. Call us on 0244 265588 or 0302 811163. Lesh Fortune Limited.
Lesh Fortune Limited, unleashing luxury with perfection, one space at a time.
Lesh Fortune Limited.
Eye bribi kitua bi na yede bo nya yedo ho ban. Ohwepa enye dede na emom eni se obenya bre ahweyie ne enioma kitua bi a yebeye no yie.
Oja ashwaye she asefreme so na hwe me hu ye de biara.
Good conduct, great life is brought to you by
Indomie.
Tastes great.
More Kivo inside. Kivo Gary Soaking Mix. Taste of Ghana.
Cadbury hot chocolate. Crafted from cocoa, milk, and sugar. Creamy, chocolatey, frothy goodness, rich taste, so satisfying.
Cadbury goodness, the treats you deserve every day.
Well, welcome back to The Probe, and I have in studio the Director General of the Ghana Health Service, and we are looking at issues relating to the recently launched free primary health policy by this government, and he's been explaining they are the implementers of the policy. Now, before we went on the break, you were trying to explain to us a few points with regards to retooling and all of that. Kindly land on that point.
All right, so Mr. Carlos, here's the issue. The policy does not intend for people to rush to hospitals or rush to health centers or rush to polyclinics. The intention is for us to get the people in their home setup, okay, in their communities, and provide the necessary services to them. So technically, you are taking less people to the hospital. Technically, the intention of the policy is to develop a health culture. That we are doing it, very soon we go to school level, we go to everywhere, then you say, okay, now the people understand their environment. They understand that it's about one health. Animals can lead to their sickness. Water bodies can lead to more malaria. They will understand that in their house, so they get that health education. And then two, they will understand their own health problems. They will understand what is diabetes.
So they know the dangers?
They know the dangers, the risks, what that means.
Okay.
And then they will take the measures to take good care of themselves. When that happens, few people will go to the hospital. So when we start, we don't intend that. I do know, and I do foresee, a lot of people will start, it's free, so we are going to a health center for this, we are going to this for... No. The whole intention...
That clarity is very important, because I've heard people who are saying that they're going to... So it means that we still have to be at home?
No, we will come to your houses, right, as part of the prevention and promote activities. We will give you good care there, and if we fail, you move to the next level,
okay,
where you get access. Now, if you look at it, even the kiosks we procured for this exercise, which we said they will be in lorry stations, markets, this is what will happen. If you are in the market center and you fall down, it's an emergency. Instead of them rushing you to the hospital to go and occupy a bed because of hypoglycemia, your sugar level went down. You move into that small kiosk, they deal with it. Inside there is telemedicine. That's technology I'm now talking of, which is connected to a hospital, Rich Hospital, Legman Hospital. Then, when that nurse in there cannot deal with you, we place a call. I have Mr. So and so. This is his problem. To a doctor there. So, okay, give him this. Whilst we arrange for your transfer or your recovery.
So we'll have all these kiosks in where? Lorry stations,
I'm just
markets.
doing in market areas and hard to reach places that don't have the chips.
Okay.
The right areas.
That point has been made. Let's look at retooling.
Yeah.
It's very, very important to this conversation because
Absolutely.
if you're going to be checking people's health, I mean, to diagnose them of their conditions, you need to have the laboratories and all the infrastructure to be able to do that. So tell us, how much of that retooling have you been able to do so far?
Right. So, Mr. Carlos, we just don't retool because equipment alone don't do the work. We started with doing human resource gap analysis. And we say, okay, to move from home to the health, to move from the chips to the home, this is the number of people we need.
How many people do we need?
You need the community health nurse. You need it depends on the place. You need a volunteer, minimum of 2 to start with, right? And you have a motorbike with helmet for them to go. You have a
2
tricycle.
separate motorbikes?
No. One-on-one. You have, let's say, a tricycle. The tricycle can contain 2 or 3 people plus the one riding it, which would be a part of the... So you have the community health nurse, the volunteer, you can have the community health officer. So let's say 3 now, okay? Then at the back of this tricycle, you have your vaccine ice chest, you have your bag that contains your weighing scale, contains some emergency medicine, it contains what you need to do, and then some chart. If you have the houses that you are planned to go to that day, if they are small children and you want to check their ear or you want to check their eye, you have all that. You look at it, they are doing that in your house. They'll come and check that in your house. Okay?
At no cost.
At no cost to you. All right? Then we now say that, okay, if the person comes to the chips itself, what do we need? So at the chips level, what do we do there? Then we say, okay, at the chips level, this is the category of human resource you need. Right? Then we say, okay, if that category fails, you need to go to the health center.
Yeah. So I want to know, because of time, how much of that have you done so far?
We've so far
when it comes to the retooling, going to the people's homes and all that, and then to the chips compound, how much of it have we done? What form of retooling have we been done?
So far, we've been able to calculate that to start with the 150 that we said we will start. Okay? So, and we are starting it that way because I try to explain so that people understand that from the chips, then you go to the health center. It also has this category of retooling that when you fail at this level, there will be the necessary
Let's take it this way.
Human resource.
The 150 districts.
Yes.
How much personnel, how many personnel do you need to do this job?
All right. So if you take the 150 districts, it differs differently depending on if you take the polyclinic, the health center, the chips compound. So for instance, let me give you this data that we have in there, okay? We have in grand total, right, that you can see over 7,000 chips compounds. Of them, we have them by regions.
That's what we have across the country.
Across the country.
7,000.
7,122. I'm just giving over 7,000 so that we see.
Okay.
Health centers, we have about 1,180. And polyclinics. But with that, we are going to now reduce to 150 districts. Now, in the 150...
Now, let's get that clear. We are going to reduce what?
We are going to start in 150 districts.
The rollout of this policy.
Yeah, 261 districts. And we are starting with 150.
Good.
You get what I mean? Out of the 150, we now look at it and say, in this district, right, they have, let's say, 28 chips compounds, or they have 2 polyclinics. They have only 1 district hospital, and they have, let's say, 5 health centers. For the continuum of care, they have to be linked to each other. These are those we will be considering. And then you have the number of human beings calculated per category. And then you have the equipment also per category distributed to this.
All captured within the 150
All
districts.
captured within the 150. And pay attention to this. The 150 districts is not 150 facilities.
Sure.
Right?
Because
in
one district could have many facilities. Right.
And that is why I was also talking about the criteria to say someone is deprived and you prioritize them. I was going to Afram Prince on Wednesday. You need to catch a ferry to catch another one to go there. Good, right? You go there, even within Afram Place, you have Donko Krom, you have another this, you have different places. It varies.
Okay.
You can't compare Afram Plains to Jamestown.
Not at all. So, but back to my question.
So we prioritize that, even within the same district.
So human resource, any new, employment, let me put it that way, for this rollout as we speak?
Absolutely, yes.
What are the numbers?
Let me say this personally so that maybe Ghanaians will understand. Immediately we launched this, the minister spoke about financial clearance for health workers, and not only for nurses, but it's nurses, laboratory technicians. As you know, the portal was open on the 16th. Okay? Now, we are going to employ. But there is something even...
You are going to employ?
Employ, because the portal is open.
For this particular policy?
I'm coming. Let me explain so that people understand. People have graduated, and especially this policy will need a lot of nurses.
Do you know the number?
Of different... Yeah, you'll be looking here. I'm coming to talk to you about it on the screen. Now, what will happen is this. We have nurses 2021, 2022 batch, 2023 batch, 2024 batch that are home. There are two things. They can keep being home, or you can employ them to support as volunteers who already have knowledge of health to support the policy. And when we open more, we get more financial clearance, they will be absorbed because they were already contributing as volunteers.
So trained nurses who are home, who do not have jobs, can volunteer.
Yeah. And they will be paid something. Stipend. No, Ghana volunteer doesn't mean, how will he go to work?
Okay.
Or how will he or she...
Averagely, how much? Because there are people listening.
We are working on that. We will talk about that so that by the time I leave here, there are thousands of people saying I should give them a job.
But the assurance is that many of them who volunteer will get rolled into the system.
Absolutely.
Eventually, when you have the financial clearance.
Now, look at this interesting thing. Look on the screen, okay? I have been vilified, and I want to say this to Ghanaians to understand. When I became Director General, I tried to do a realignment of the health system, the workforce, moving people around. We did not sack anyone. It's just about saying, oh, you've been here for 20 years. Move to the next place. You've been here for this time. Move to the next place. Because of that, I got people, even as at yesterday, somebody called me, oh, we are investigating you. I say, for what? So, because you transfer somebody and we are going to chase you. And I said, look, I don't have time for this. I have a policy now, free primary health care policy. I have to think through and make sure that it happens. So I can't grant you interview about you investigating me. It will be coming out. I don't really mind about that.
Okay.
And the simple reason is that you have 6,245 nurses excess at a level that we consider as a gap.
Let's get the number again.
No, it's right there. Mention it.
Which level are you talking about?
Read the last one. Ability to reassign excess.
Okay, this is where we are.
Yes, that's where we are.
Ability to reassign the excess community health nurses. 6,245 to Chiefs Compound. Level to have reduced the existing staffing gap. So it means that these 6,265 are at a level that they are doing nothing at all.
No, don't use that word, please. They are working.
But excess capacity.
But that is not the level where they should be. Because, you see, people sometimes understand that, oh, I want to be in Accra. So everybody comes to Accra in Kumasi. That's cool, right? But the same way, within Kumasi, people want to be in Kumasi Central.
So what is going to change?
So now, I and the team will sit down, and I wanted you to finish reading. It says that if we reassign, would have reduced the existing gap staffing from 6,799 to 554. So now we are going to realign this. And this is where I'll get more problems. Oh, don't transfer this person, it's my wife, or it's my nephew. And I'm talking to Ghanaians. Oh, don't do this. This person is already there. No, we want to realign them so that this policy will work. Because at the end of the day, if we don't do this, they will tell us. The
message is that under this policy, there will be heavy realignment.
It has to.
Of health workers.
It has to.
Doctors?
I say it has to do. Health workers. Just say health workers.
How soon is that going to happen?
Pretty soon. Because it will allow us to actually employ the numbers that we need to employ. Okay. And it will allow us to really deploy the staff to do exactly what they've been trained for and provide quality of care. These are, if we are not able to do this, these are the same people who come and say, oh, the policy failed. Okay. It didn't work.
Good. That point made. What number are we looking at in terms of fresh employment?
So you can... when the portal opened, we looked at it was 3,000 we were thinking of in different categories, okay, for laboratory technician. Because as I said,
the policy is for which specific?
Is different categories. I can provide you the data because I have the data here, and if you allow, I can do that so that you know that for laboratory technician is this number for for nurses, health nurses, we need this number for this. And they already know because we open it in the portal. Okay. Are you getting me? Okay. So if you are at the health center level, this. If you are at the polyclinic level, this. If you are at the CHIPS compound level, these are the things that we will be doing. Okay. I hope you understand.
Right. So we'll get to those figures pretty soon. Let's look at the retooling. Yeah. We've heard of some motorcycles and tricycles that... what is the issue? I know the president has been speaking about that, but from where you sit as an implementer, what is really about it?
Mr. Carlos, I will say this. We have a syndrome of no bed. One person dies, the whole country cries, which I join them, and I join the family. I sympathize that nobody should lose his life. Okay. And then we see that to be negligence for the doctor. But at the same time, we now have a system that is bringing promotion and prevention that will avoid many people to die. And you have people in the community wanting to play politics with it. That is collective negligence.
The point is?
And the point is that those motorcycles are not ambulances. And they were not procured as ambulances, and they don't intend to work as ambulances. Those motorcycles are intended to take the community health nurses, the volunteers, to the community, to your house. And then they will have, let's say the temperature is 40 degrees. You have a tricycle, it covers you. It's raining, you have a tricycle. Between that and motorbike, which one would you prefer? You have a bag to carry. You have a place you put the bag in. You have vaccines. You put the vaccines in there, and then you ride and you go.
The president explained that this particular one is not supposed to work in metropolitan areas. Is that the page?
Well, let me say this, okay? Let me finish with the idea. I've also seen people talking about the road network and all that. Right. Look, go to Holland today. They are using bicycle more than, and they have better roads than us. Go to China. They use motorbikes more than us. Okay. So the motorbike is not just about the road. It's a means of transportation for the community health nurse to be able to reach where she has to go to safely.
How many of those have you procured?
So we are planning that we should have each CHIPS compound should have either a motorbike or a tricycle. It will also vary from place to place. We have, as His Excellency explained, up north we grew up riding bicycle and motorbikes. So whether ladies or female, we can navigate through. Okay. Down south.
As we wrap up the conversation, how sustainable? Yeah, 1 hour is over. We have a lot to talk about, but as we wrap up the conversation, how sustainable is this particular policy? Looking at the cost component, the fact that you need a lot of health workers to employ almost every year. How sustainable is it?
This is the most sustainable activity that any country that wants to improve its healthcare will adopt. And all the countries, I've said it from the beginning, who have good health system with high level of life expectancy and productivity, they are running on free primary healthcare. Because it's a way of freeing, in the long term, you are freeing a lot of money into the national health insurance. Because
but of course, the national health insurance is a major concern because the funding, we are told, is going to be coming from the national health insurance.
Of course.
Would that not cripple the national health insurance?
No. That's what I'm saying. That less people will go for curative services. Less people will go. So you pay less. You have a brain tumor detected when you're small. You come to the hospital. Surgery is easier than if you're home, you detect it and you come and will have to do 3 phases of surgery. Or you have stroke. Now you come, they have to pay more. But this one, it takes you 5 cities. You take care of something as to leaving it to grow to 2,000 cities. Why would you do that to yourself? So, as I said, there is this I call the collective negligence that all Ghanaians listening to me should see that if we allow more people to die, our children at home, the newborn, pregnant women, not to have this kind of screening, it's a collective negligence. We should all come together, embrace this, and we'll have a better life expectancy. And the youth will not be condemned to be carrying people with stroke to the hospital. Everybody will enjoy and live higher life.
So this policy is not new at all?
It's new on all the things I've told you. That will be done. That we are coming to your house, bringing you health to you. It's new because at the end of the day, you will know much about health than anyone. You know much about yourself, about your environment, more than anyone.
Right.
It's new because you are not paying. And it's new because when you are being referred to another place, there is somebody waiting for you and already knows your problem. Do you get what I mean? And it's new because when you get in there, your problems are solved for free.
Thank you so much, Doc, for speaking to us here on The Probe. And of course, you can catch the interview again on our social media platforms. My name is Carlos Calony. Thank you so much for watching. And you have been listening to us also on Joy 99.7 FM and Love 99.5 FM in Kumasi. Catch us again next week for another exciting edition of The Probe. Bye-bye.
I am Anas Sabit on the principal streets of Techiman, and this is Joy News. Independent, fearless, and credible.
Did you know that some videos circulating on social media falsely claiming to be from Joy News and advertising some drugs are fakes? These fake videos advertise unapproved medicines using deep fakes of our presenters to endorse these medicines. Here's one example.
Blood pressure exceeds 120/80, internal organs are affected, and a stroke occurs. A famous doctor has developed a drug that prevents high blood pressure.
You can learn to spot these fake videos. Here's how. The first sign. Notice how the lips of the anchor do not exactly match the words being spoken. Also, pay attention to the Joy News logo in the bottom left corner.
Why is it that rich people always, or wealthy people are into philanthropy? Because they have to give back. What is the thrill of creating and solving problem that makes them do that? Money is a consequential, effect of whatever it is that they're doing. So eventually everyone will give their money away. Bill Gates, all of them, Bezos, they're all going to give that money away. But the fact that they solve a problem for humanity is what drives them. That is what makes them happy. So it's not, whether it's on the Bezos side or just a small business, online business on Instagram, whatever it is that they're doing, monetary aspect may not necessarily be the core. You can start with that, which is fine. But the more you grow, the more you see, wow, I'm actually doing something that is touching people, the monetary aspect becomes secondary.
Turn around. Turning point. Yeah. He's a turnaround. Hello and welcome to Springboard, your virtual university. My name is Albert Okran. Welcome you to Ghana's foremost developmental program and that place where the greatest minds in the world converge. Springboard is brought to you by the Springboard Roadshow Foundation in partnership with MTN Ghana, the Enterprise Group, and the Ghana Growth Program. a collaboration between Mastercard Foundation and Springboard. Our media partners, Joy 99.7 FM, Joy News Television, and the Graphic Group of Newspapers. You can also find our past editions on the Springboard channel on YouTube. So this conversation is about the entrepreneurial mindset. What kind of thinking, what kind of orientation is required to be a successful entrepreneur? Are you born with it? Do you acquire it? Can it be transmitted genetically? Is it hereditary? We'll find all that out today because my guest is very well equipped to provide us with answers, insights, understanding of entrepreneurship. Andrew Aka is my brother, friend, and it's good to have you here, Andrew. Thanks for coming.
Thank you very much, Reverend. Good to see you.
Good to see you too.
I've been meaning to come to your studio, so it's great. It's great to be here finally.
They say it's been a long time coming.
It's been a long time.
Yes.
Thank you so much.
What do you think of the subject of the entrepreneurial mindset? What are your thoughts on it?
I think before we try and define what that is, I'm not a big fan of defining something in a box, but I like to say this: there are people who inherently have a certain, they have a certain difficulty continuing to live in their lives without solving problems, because as it were, as humans we have various sort of problems to cure, to solve. So if people identify that they can do something to help, or they can do something to provide, or they can do something to enhance humanity, lifestyle, whatever it is, they have, that problem is in them. And until they birth the solution for that problem, they become restless, right? Others will say that it's just because they want to make money and they've seen an opportunity to make money. So people have their own theories, but I think if you to wrap it up, it's just it must be within you. You must feel something to want to do. You must, we all created to multiply, to create. And if you have that in you and it's a burning desire and you want to do that, I think that you have the opportunity to learn the principles of entrepreneurship and then start a process, a system that can continuously churn out the solution that you have, burning inside of you.
So Andrew is the CEO of Dentsu Ghana, and he's the president of the Advertising Association of Ghana, a very thriving, vibrant group of intelligent people providing solutions. And you're saying that it really starts with having a solution to a problem that you identify.
Yes.
So with Dentsu, what problem did you set it up to solve, or did you set out to solve?
So Dentsu is a global company. I mean, they purchased the business that we're running locally here, and the solution we provide is to partner or collaborate with clients to solve their problems. As consumers of products and services, you know that there's competition, right? So, and there's limited budget. So everyone wants to sell their product. Everyone wants to sell their solutions, and there are various channels to sell their product and services. So what we provide is a marketing solution, but layered in that is the innovation that we bring along, is the tech that we bring along, is the data analysis that we bring along, is the thinking, the strategy that we put together to solve clients' problems. And I think it's been an interesting journey, but the soul of our business is not just the data, and I think it's the culture that we have built that is appealing to client, because we listen, we understand, we see our clients as an extension or we see ourselves as an extension of our client's business. And that respect, that integrity, that understanding of the client's business, thorough understanding of the client business, and partnering with them, and not just giving them solutions and going, but partnering with them and caring about their business, and celebrating with them when the campaign works and their market share is growing, but also be with them when they have tough times, right? And now, during COVID, for instance, all clients say, look, we can't pay the sort of retainer that we used to pay because we are going through. So we had to agree to cut down, our retainer because we're in crisis. So I think those are the little things that clients look out for, not just the core function of providing advertising solutions or marketing solutions in their thinking, but also truly believing